Welcome back to the Deep Dive. This is where we take your source material, your notes, and really unlock the key insights.
Exactly.
Today we're tackling a really critical medical topic, HELLP syndrome, based directly on the revision notes you've shared with us. The goal here is simple: get you completely up to speed on HELLP. Fast, clear, and hopefully memorable. Think of this as your targeted study session.
That's the plan. We're going to unpack these notes systematically, point by point, covering, the definition, causes, right through to management and complications.
Yeah, the focus is on clarity and helping you really retain the essential info from this source material.
Precisely.
Okay, let's get into it then. We've got notes covering, well, the full spectrum. Definition, etiology, risk factors, pathophysiology, differentials, epidemiology, features, tests, management, prognosis, and complications. It sounds like a lot, but we'll make it make sense.
We will.
So, first things first, the definition. Your notes call HELLP a severe pregnancy complication.
But that acronym, HELLP, what does it actually stand for? That's kind of the main memory hook, right?
Absolutely essential. H is for hemolysis, EL stands for elevated liver enzymes, and LP is for low platelet count. It's right there in the name.
HELLP, hemolysis, elevated liver, low platelets.
And your notes get specific on the criteria. For EL, it's elevated liver transaminases, ALT or AST, typically over 70 IUL.
Okay.
For LP, it's a platelet count under 100 times 10 to the 9 per liter. And the notes also mention LDH, lactate dehydrogenase, needing to be 600 IUL or more, which ties into the hemolysis usually.
Got it. So blood cell breakdown, liver trouble shown by those enzymes, and a low platelet count confirmed by that number. The notes also mention it's a variant of pre-eclampsia.
Yes, that's a crucial link. You often see it alongside or as a severe form of pre-eclampsia.
So you might get the hypertension and proteinuria too, maybe RUQ, pain, headache, nausea, vomiting, just feeling generally unwell, that kind of thing. Exactly. Those symptoms listed in your notes often accompany it. And an important point from the notes, sometimes you might just see unexplained low platelets, thrombocytopenia, without all the other systemic signs, particularly postpartum. Something to watch for.
And the H-bit, the hemolysis, how is that confirmed? The notes list a few things.
Yeah, so for hemolysis, the notes say you're looking for signs like elevated bilirubin, that high LDH we mentioned, maybe worsening anemia, and importantly, seeing cystocytes, those fragmented red blood cells on a blood film.
Okay, so the lab tests really pin down each letter of HELLP. Pretty clear.
Definitely. HELLP with those specific numbers and the hemolysis signs.
All right, so that's the what. Why does this happen? The notes mention etiology.
Yep.
What are the underlying causes thought to be?
Well, the source material points towards problems starting with the placenta, like abnormal development there.
Okay.
And then there's mention of immune system dysfunction. And a really key factor seems to be endothelial cell dysfunction, basically. Problems with the lining of the blood vessels throughout the body.
So the placenta kind of kicks things off. And then the body's reaction involves the immune system and the blood vessels.
That seems to be the thinking, yes. It's the systemic response.
And who's more likely to get this? Your notes lists several risk factors.
That's right. The notes mention a few categories. There's age, being over 35, being pregnant for the first time, nulliparity, having a history of gestational hypertension in a past pregnancy or carrying multiples, and very significantly, having had HELLP syndrome before really increases the risk.
Right.
Caucasian racial origin is also listed. And then there are medical conditions, specifically Antiphospholipid Syndrome, APS. The notes state it's associated in about 10.5% of cases.
That's quite specific. So grouping them helps. Age and parity, past pregnancy issues, previous HELLP, and then conditions like APS.
Exactly. Helps to keep them organized in your mind.
Okay, let's dig a bit deeper into how it causes these problems.
Yeah.
The pathophysiology mentioned in the notes.
This bridges the gap between the cause and the effects. Your notes highlight inflammation, that endothelial dysfunction we mentioned, the damaged blood vessel lining, platelet activation throughout the system, and direct damage to red blood cells.
So those processes, the inflammation and vessel damage, they directly lead to the H hemolysis, the EL, liver dysfunction, and the LP, low platelets, that define the syndrome.
Precisely. That's the connection. The underlying placental and immune issues trigger this cascade that results in the HELLP criteria.
Makes sense. Okay, so if someone presents with these kinds of symptoms, maybe upper abdominal pain, maybe blood pressure issues, and these potential lab findings, What else needs to be considered? Your notes have a list of differential diagnoses.
Yeah, and this is clinically vital. You have to rule out other serious things. The notes mention acute fatty liver of pregnancy is another severe liver issue specific to pregnancy. Then conditions affecting blood counts and clotting, like TTP, thrombocytopenic purpura, and ITP, immune thrombocytopenia, both cause low platelets. Also, hemolytic uremic syndrome, HUS, which involves kidney issues, hemolysis, and low platelets too.
So other big players affecting liver, platelets, kidneys, or causing hemolysis. What else?
An acute flare-up of SLE, systemic lupus erythematosus, is on the list. Also, viral hepatitis, which directly affects the liver, and cholangitis, an infection of the bile ducts.
That's a broad list. It really underscores what the notes say later about needing a high index of suspicion, doesn't it?
Yeah.
To think HELP, but also consider these others.
Absolutely. You need to differentiate carefully.
How common is HELLP? The notes provide some UK epidemiology figures.
It's relatively uncommon overall. The notes say between 0.5% and 0.9% of all pregnancies, but it's much more common in women who develop severe pre-eclampsia, and it usually pops up in the third trimester. Importantly, the notes stress it can actually be the first sign of pre-eclampsia developing in some cases.
Okay, so thinking about the clinical picture, what would someone actually experience? What are the key features mentioned in your notes?
The symptoms can be quite varied, and sometimes a bit nonspecific at first. Upper abdominal pain is a big one, often tenderness in the right upper quadrant or epigastric area.
Okay.
Nausea, vomiting are common. Headache, feeling really fatigued or generally unwell, malaise. Some might develop jaundice, swelling or edema, and high blood pressure. And of course, signs of organ dysfunction if it's severe.
And the timing is really critical based on the notes.
Extremely important. While it happens during pregnancy, a significant chunk, around 30% according to the notes, actually presents after delivery.
30% postpartum, wow.
Yeah, usually within the first 48 hours, the majority, 70%, present before delivery, often between 27 and 37 weeks. But that postpartum window is crucial not to miss.
That really stands out. People often think pregnancy issues end with delivery. Spotting this afterwards is vital.
It really is. And as the notes point out, initial symptoms like headache and malaise are pretty common anyway. Visual symptoms occur in about 20%. There's a specific detail in the notes, too. Symptoms often worsen at night and get better during the day.
Interesting pattern.
Yeah. And with low platelets, you might see easy bruising or purpura, those little spots under the skin.
And physical signs a clinician might find.
The notes mention hepatomegaly, an enlarged liver, edema, the swelling, and hypertension. So diagnosis really involves putting together the timing, the risk factors, the symptoms, and then nailing it down with those lab tests.
Right, linking symptoms back pain, nausea to the liver EL, headache maybe to BP, bruising to LP could be a useful memory aid.
Definitely.
So if HELP is suspected based on all that, what tests confirm it? The investigation section in your notes.
Well, as the notes stress, it starts with that high index of clinical suspicion. Then the tests are focused on confirming the HEL and LP. So blood tests are key. You need liver function tests for the ALT and AST, a full blood count or complete blood count to check the platelet count and look for signs of hemolysis like the schistocytes or anemia.
Okay.
Urine analysis for proteinuria is standard given the preeclampsia link. And imaging, maybe an ultrasound, might be used sometimes to look at the liver, especially if there's severe pain.
But the blood tests are the core for hitting those diagnostic criteria numbers and confirming hemolysis.
Exactly. Your notes make it clear that's where you see the hard evidence. The liver injury markers, the low platelet number, the signs of red cell breakdown. And they also mention that how abnormal these labs are, the severity, is linked to worse outcomes for the mother.
That makes sense.
Yeah, it underlines why getting the tests done promptly is so important. There's a mention in the notes of a less common test, plasma glutathione S-transferase A1, IDGST, which can indicate early liver damage but isn't widely available. So practically, it's bloods for H, EL, LP, and urine.
Okay, got it. So once it is diagnosed, what's the management approach according to these notes?
The absolute cornerstone of management, based on the notes, is close monitoring of both mother and baby, controlling the blood pressure, and, crucially, delivery. Delivery is seen as the definitive step for resolution.
Delivery is the cure, essentially.
For HELLP itself, yes. The notes specify delivery is generally indicated after 34 weeks if there's multisystem disease present. Before that, it's a balance of risks, often involving corticosteroids for fetal lung maturity, if possible.
What about specific medical treatments mentioned?
The notes detail the key medications. Magnesium sulfate is given intravenously to prevent seizures, eclampsia, which is a major risk.
Right.
It's often given alongside intravenous dexamethasone, according to the notes. For high blood pressure, if it's over 160/105, antihypertensives like labetalol or nicardipine are used. The notes explicitly state delivery plus IV dexamethasone is the first-line approach for acute HELLP.
And managing the blood abnormalities.
Yes, supportive care there is important. The notes mention considering cryoprecipitate or fresh frozen plasma if fibrinogen levels are very low, below 100 milligdl. And platelet transfusion might be needed if platelets drop really low. The notes say below 25 times 10 to the 9 per liter, sometimes with anti-deimmunoglobulin. In extreme cases of liver damage, liver transplantation is mentioned as a last resort.
Wow. So, main things. Monitor, manage BP and seizures, deliver, support bloods as needed.
That's a good summary. Monitor, medicate, blood products, and deliver.
The notes also touch on non-prescribing management, though it sounded like actual prevention is tricky.
Exactly. The notes state clearly no specific proven prevention for HELLP. The points mentioned seem more about managing related risks like pre-pregnancy weight loss advice for obese patients or ensuring good compliance with BP meds for those with chronic hypertension. It's more about optimizing general health.
Understood. So what's the outlook, the prognosis section in your notes? How do women and babies fare?
It really varies, depending on severity and how quickly it's managed. The good news is most women recover well with prompt delivery and supportive care.
That's reassuring.
However, the notes mention some might face long-term liver issues, and there's a stark warning. Without early treatment, up to 25% of women could develop severe complications. For babies, sadly, the mortality rate can be significant, mainly tied to how premature they are at delivery.
That really hammers home the importance of early diagnosis and the management steps we just discussed.
It absolutely does. The potential outcomes make understanding this condition critical.
And on that note, the final section in your notes details the complications. This sounds like where it can get very serious indeed.
It can, unfortunately. The notes list quite a few potential complications for both the mother and the baby.
Let's start with the maternal ones listed.
Okay, the notes mention eclampsia, the seizures, in about 4–9% of cases. Placental abruption, where the placenta detaches prematurely, is listed at 9–20%.
High risks there.
Yes. Then there's DIC, disseminated intravascular coagulation, that major clotting disorder with a very wide range given, 5–56%. Acute kidney injury, 7–36%. Severe ascites, fluid in the abdomen, 4–11%. Cerebral edema, brain swelling, 1–8%. Pulmonary edema, fluid in the lungs, 3–10%. Wound infections after C-section, 7–14%. And then the really severe, thankfully rarer things like liver rupture, retinal detachment, stroke or cerebral hemorrhage, and tragically, maternal death, with a range cited from 1 up to 25%.
That's a devastating list of possibilities. What about complications for the baby?
For the baby, the notes list perinatal death, occurring in 7–34%, again, very dependent on gestational age. Intrauterine growth restriction is seen in 38–61%. Preterm delivery is almost a given, 70%, and 15% of those are very preterm, before 28 weeks. And neonatal thrombocytopenia, low platelets in the baby, affects 15–38%.
Seeing that range of severe outcomes, abruption, DIC, stroke, kidney failure, perinatal death, it really raises the question again, doesn't it? How absolutely critical is timely identification and management based on these notes?
It's paramount. As the potential complications listed in your notes make devastatingly clear, recognizing HELLP using these criteria and implementing the management strategies promptly isn't just best practice, it's potentially life-saving for both mother and baby. The stakes are incredibly high.
So we've really done a deep dive into HELLP syndrome there, working through your revision notes from definition right through to those serious complications.
We've covered the what, why, who, how, and the what ifs, all based on the source material you provided. Hopefully, breaking it down like this has helped clarify things and solidify this complex topic for you.
Absolutely. It's a stark reminder of why recognizing these signs is so crucial. And speaking of being prepared, knowing this material cold.
If you are preparing for exams or just want to reinforce your knowledge on medical topics like this, there are some great resources out there.
Yeah, definitely check out pastorlevy.com and also freemsra.com. They offer more information and tools that could be a really good next step after this deep dive.
Thanks for joining us for this focused exploration based on your notes.
Until the next deep dive, keep learning.